And we are live. This is exciting. Well, hello, friends. We made it pretty much on time today. I am so thrilled to be live with you. As you can tell, I'm not at my normal home office here, but I am in the beautiful Aloha State. I am here with my family in right outside of Kona here on the Big Island, and it's been just a wonderful time of relaxation and rejuvenation at the end of a very busy month. So I'm thrilled to be live with you today and bringing back our special guest. Welcome and thank you for joining us for our special educational symposium entitled How to Live Your Best Life with Lupus, a special live virtual event in honor of Lupus Awareness Month and in collaboration with the author of the Lupus Encyclopedia with its second edition out on Amazon and various other outlets where you can buy books these days, and the creator of the lupusencyclopedia.com, Dr. Don Thomas. My name is Kelly, and I am the creator and executive director of Portland-based nonprofit More Than Lupus. And if you're unfamiliar with More Than Lupus, we are a multi-ethnic, multi-generational, and international lupus community designed by lupus patients to connect and to grow and to inspire each other throughout the peaks and the valleys of our lupus journey. And I say "our" because I have lived with systemic lupus and multiple lupus overlap conditions since the young age of 11. As a pediatric patient, I have been through the trenches, so I'm speaking with personal experience when I say living with this illness can be tricky, and we want to help you as much as possible to live your best life with lupus. Now, we believe every person with lupus, no matter their background, should be treated with equity and dignity and taken seriously. And it's our mission that patients feel heard and seen and valued. And today's event will spotlight the many ways lupus intersects with the many aspects of your life and how, as patients, you can be proactive and less reactive with your health. And we hope the information today provided not only helps you, but your close family as well. And also, there will be a question and response time at the end of today's presentation, and all the informational sources cited today will be available for you as well at the end of the program. So please write down any questions you may have and write them in the chat box, and I will do my best to vet them and get them to Dr. Thomas before the end of this session. We are coming to you live from Facebook and YouTube. And just a reminder that any spam or inappropriate material or negative comments will be prohibited. And I will be doing my best to monitor that from behind the scenes. So please keep all comments positive. And as I mentioned, any inappropriate material will be deleted. And all you have to do is refresh your page. By the way, please share this. You know, the more you care, the more you share, the more other people are aware. And we want people out there to have access to this wonderful information today and a community of support. So please make sure you share this on your personal Facebook page. So before I click myself off here and hand over the reins to Dr. Thomas, let me give you a brief disclaimer. Please understand that the opinions shared today are purely for informational purposes and do not replace the medical advice and/or opinions of your doctor. If you're experiencing lupus or lupus nephritis or lupus overlap symptoms, it's important to follow up with your doctor and seek the treatment that is best for you. Our panelist today is a qualified professional. However, he is not liable for his comments since he is not acting as your personal physician or health advocate. So let me, without further ado, introduce Dr. Thomas. Hello, Dr. Thomas.
Hello, Kelly, and thanks for having me.
Oh my goodness, so happy to have you back. You know, I know many people in our More Than Lupus community know who you are because we have collaborated over the years on many events. But would you just take a moment to talk a little bit about your background and share with us the work that you've done over the years in the lupus realm?
Sure. So I'm a rheumatologist in private practice in Greenbelt, Maryland, just right outside of Washington, D.C. I've been in practice for over 30 years, specializing in the treatment of people with lupus and Sjogren's disease and systemic autoimmune diseases. But one of my biggest passions is teaching and educating and motivating patients as well as physicians on how to take better care of lupus patients and themselves. And I'm really excited because, and I'm also a professor at the Uniformed Services University in Bethesda, Maryland, where I teach fellows and medical students, and I just love educating people. And as you said, I wrote the Lupus Encyclopedia. Not only is it a helpful book for patients, but also comprehensive enough for physicians to know how to treat their patients best.
Wonderful. Well, take it away, Dr. Thomas.
All right. So last week, I was in Toronto, Canada, for the biannual International Lupus Congress. And what this is that the world's experts in lupus, they congregate together and they share the research, latest research on lupus, and that's something I wanted to share during this talk today. Toronto, I'd never been there before. Unfortunately, it was the coldest May since 1967, and it was rainy the whole time. But one thing I learned that I'd like to share about Toronto is it has the highest observatory in the entire Western Hemisphere. And I went up into the CN, it's called the CN Tower. Never go there, you have to go up there. And my hotel had 38 floors. I went all the way up to my hotel, thought it was amazing. But then when I went up to the observation tower, the CN Tower, my hotel looked like a little tiny thing down below. It was just amazing. But anyways, the biggest thing from this Congress and conference was that it was a celebration of lupus experts sharing with the entire world, doctors and healthcare providers all over the world, on how they can better take care of lupus patients. And so I wanted to share with you some of that information today, because it is truly an advancement in how we should be treating systemic lupus erythematosus, or SLE. And how fitting is it that this is the last day of Lupus Awareness Month of 2025. So I made a list of what I thought was some of the most important advances in systemic lupus and lupus nephritis over the past few years. And it's such an amazing thing because the American College of Rheumatology and the European Association of Associations of Rheumatologic organizations have shared guidelines on how to best treat systemic lupus and lupus nephritis. And then on the very last day of the conference, Dr. Laurent Arnaud, who's a lupus expert in Strasbourg, France, he presented an article that was just published on how to treat 24 rare manifestations of systemic lupus. Now, why is that important? Even though they're rare manifestations, meaning that even lupus experts have treated maybe just a few of each of those problems, I guarantee that many of you watching this right now have had at least one or maybe two of these problems. And there's less rheumatologists today than ever. And let's say you end up having a severe lupus problem in the middle of nowhere, your doctor has access to these articles where they can know exactly the right way to treat you. So let's get started on what I think are some of these great advances. So number one, they were teaching doctors that the aim for the treatment of systemic lupus erythematosus and lupus nephritis is not to just help our patients feel better, but is to get them into remission on medications and completely off of steroids. The reason to get them off of steroids is that even though steroids are the only drug that works immediately and absolutely helps to decrease organ damage right away, When patients are on it for any significant length of time, it is guaranteed to cause organ damage in our patients, even doses as low as just a couple of milligrams of prednisone. So we want our patients completely off of prednisone. The P in prednisone stands for poison. Number two, of course, unfortunately, not all of our patients are able to go into remission, and it just shows the great unmet need that we do need better therapies for lupus. And fortunately, there are some just around the corner. So if we can't get our patients into remission off steroids, the second best is to get them into low disease activity. And if they can't get off prednisone, to strive to have them on at least 5 milligrams a day or less. The importance of this, by the way, is that many rheumatologists were taught for decades that it's okay to keep our patients on 10 milligrams a day of prednisone or 7 milligrams a day of prednisone. But the problem is that much prednisone is guaranteed to cause problems like osteoporosis, cataracts, broken bones, heart attacks, and strokes. Number three, hydroxychloroquine or chloroquine should be used in everyone. The reason, unless it's contraindicated, by the way, for example, let's say that you developed eye problems from hydroxychloroquine, then of course we can't use it in you. But the vast majority of patients should be on these medicines, and the reason for that is whenever we have a medication, we always want to make sure that the benefits of the medicine outweigh the risk of the medicine. Hydroxychloroquine is crazy as far as the number of benefits. For example, it increases the chances for remission. It decreases organ damage in patients. It decreases flares. And it's the only drug that's been proven to prolong survival in lupus patients. And it's also one of the safest drugs that we have. The major potential most common bad side effect of hydroxychloroquine is if it deposits in the back of the eye, it can cause vision problems. But this is completely avoidable. Number one, by making sure that you're on not too high of a dose, and we can do that by checking hydroxychloroquine drug levels and making sure that that's not above 1,200 milligrams per milliliter, plus making sure that you get 2 eye examinations every year. And this is very important. I do feel that all lupus patients should be proactive in their health care. The problem is that not all eye doctors have the right equipment to do hydroxychloroquine testing. Make sure that your eye doctor is doing an OCT test, OCT, and a visual field 10-2. That is incredibly important, by the way, not just getting a visual field test, because almost all eye doctors have visual field testing machinery for a 24-2, but that's not good enough for hydroxychloroquine. It needs to be specifically for visual field 10-2, and not all eye doctors can afford to buy the equipment. So make sure you get those 2 tests, visual field 10-2 and an OCT test. If you're of Eastern Asian, if you're of Eastern, if you're of Western Asian ancestry, by the way, it's also important to get a third eye test every year, and that is the visual field 24-2, and that's because the location of eye problems can sometimes go past the 10-degree mark. And so if you're Asian, make sure you get 3 tests. Okay, so the next thing, ultraviolet light protection in everyone. Only 30 to 50% of our patients actually feel sick with sun exposure or get a rash on sun-exposed areas. But all lupus patients are ultraviolet light sensitive. What that means is that when ultraviolet light, even the lights inside my home right now, or contact the skin, they damage cells underneath the skin. Those cells release their nuclear contents, and then guess what? Your anti-nuclear antibody thinks those nuclear contents are foreign bodies combined to it, float around through the bloodstream. It can land in organs like the kidneys to cause inflammation and damage. So sunscreen religiously every day, even if you don't go outside. I have sunscreen on right now because I get skin cancer, and I know those lights can make it get worse. Whenever you go outside, you should be immediately putting on a wide-brimmed hat, even if it's for a brief time. If it's winter time, you should be wearing your sunscreen. And there's a lot of other ways you can help yourself in addition to those measures. The next one is that when patients with systemic lupus present with moderate to severe disease activity, it is recommended that we consider what's called combination therapy at the very start. What I mean by that is back in the old days, and actually even today, because some rheumatologists are still doing things that they used to do. But let's say that a patient presents with inflammatory arthritis, discoid lupus, and a positive anti-double-stranded DNA. That is not mild disease. That is moderate disease activity, and we have measures that we can figure this out. Something, for example, using something called the SLEDAI. There's another research tool called the SLE-DAS tool that rheumatologists can use. That kind of patient used to be treated this way. The doctor would put them on hydroxychloroquine and steroids, and then see how they did. Try to get them off the steroids, but guess what happens? We know that in moderate disease activity, it's very hard to get the patients off steroids compared to those with low disease activity, and they're much less likely to end up just being on hydroxychloroquine by itself. So at the very start of a diagnosis, we should be adding a biologic or an immunosuppressant. And that was not done very often in the past, but today it should be done. For example, this patient with polyarthritis and discoid lupus, they should get hydroxychloroquine. I would give them a shot of cortisone into their buttock muscle to calm things down quickly, but also add a biologic like Safnello or Benlysta, or an immunosuppressant like methotrexate or mycophenolate immediately. And that way we can taper them off the steroids much faster than we used to in the past. The next one is that, and by the way, these articles are published in the literature right now, and all doctors and rheumatologists have access to them. But I think that you, as a patient, should be proactive. You can actually find these articles yourself and give the links to your doctor, or even give them a copy of the article itself. And Kelly's going to post these links in the comments section, I think, at the end of my talk. The next one is that we should be assessing adherence to medications in our patients. Guess what the #1 cause of patients not doing well with their lupus is? It is not taking their medicines regularly. Most patients are not taking their medicines regularly. The way that I learned this, by the way, is back in 2016, my clinic was very similar to other rheumatologist clinic. Many to most of my patients had active disease and were on steroids, and it was just frustrating that I couldn't get them under better control. But then a miracle happened. Hydroxychloroquine drug levels became available. I started testing it in every single one of my patients, and I was just flabbergasted that around half of my patients were not taking their hydroxychloroquine regularly. Some of them were taking 0 other hydroxychloroquine and telling me they were taking it. And so then I would show them their results, and I would just talk to them tactfully about, why are you missing your doses, or why are you not taking it? And interestingly, some of them told me they didn't take it because they didn't think it helped. With hydroxychloroquine, you're not going to feel something right away, but I guarantee you it's going to help you get into remission more than if you didn't take it, or it's going to decrease organ damage. It's going to help decrease your dose of steroids. My patients started taking their hydroxychloroquine religiously. And today, the vast majority of my patients are in remission or low disease activity, and I have few patients who are on steroids. So we need to make sure our patients take it. And even today, they're not taking their medicines regularly. Duke in North Carolina, they have a very good lupus department. They did it. They just published the results of the study where they looked at the electronic records and pharmacy fills. And what they showed is that 33% of their patients, or I'm sorry, only 33% of their patients were taking all of their systemic lupus medicines. 66% of them were not taking all of them. That's the number one reason for not being under good control. So I hope everybody watching this is taking your medicines religiously. It's, by the way, it's very easy to miss medicines. I take about 20 pills a day. So you need to figure out how to keep from missing medicines. I do have one big recommendation, is using something called PillPack. PillPack is a pharmacy that will ship you your medicines, and they all come in little packs. Like this morning, mine said May the 31st, 8 o'clock a.m. All my pills were in that little pack. I tore it open, took them, and the next little pack, and it comes in a roll, will be for 8 o'clock tonight, and I'll know I'll take it. But let's say tomorrow morning I get up and I look at my pack and it says May the 31st, 8 o'clock p.m. Then I know, oh, I forgot my medicine last night. Okay, I'll take those now. I'll take my other ones in the middle of the day, then my 8 o'clock p.m. ones tonight. Go to pillpack.com, PILLPACK.com. Most insurances do cover it. I don't have to spend an hour now every Sunday night organizing all my pills in an organizer. It's much better with PillPack. So that's just one word of advice for everyone. And by the way, I was taught about this by a couple of my lupus patients who do perfect with their medicines. And now I rarely miss my medicines, but in the past I did. The next one is we're educating doctors that they need to also make sure that we help our patients prevent heart attacks, strokes, and blood clots. The reason for that is that after the first couple of years of having the diagnosis of systemic lupus, the number one cause of death in our patients is heart attacks, strokes, and blood clots. And you might say, oh, that's no biggie. That's the number one cause of death in everyone. But it happens 10 to 20 years earlier than it should in people who are the same age and gender that you are. And the reason for this, by the way, is number one, the systemic inflammation from lupus, not only causing arthritis pain and lupus nephritis, but attacking the blood vessels where it ends up causing clogging in the blood vessels. And then 30 to 50% of our patients have antibodies that actually cause blood clots as well. So it's important to know your numbers. I recommend that my patients know what the goal for their blood pressure is, their cholesterol, their hemoglobin A1C or glucose, their BMI for weight. And then every time you see your doctor, you should ask what your numbers are and say, well, what is my goal? And if I'm not at that goal, what can I do, doctor, to get it perfect? And just an example, for blood pressure, we recommend that patients, the American College of Cardiology now recommends that all patients have a home blood pressure monitor at home and check several blood pressures before all doctor visits. Write them down, hand it to your doctor when you see them. Don't go by what we get in the office. We want to go by your home blood pressure readings. And your goal is the top number should be less than 125. The bottom number should be less than 80. Almost all the time. If your blood pressure is 130 over 81, that is high blood pressure, and that needs to be treated because that's going to help prevent these bad things. But also diet, exercise, cholesterol, and all the other things I mentioned. Number two, we need to help prevent infections in our patients. I feel strongly that rheumatologists should be the ones who are in charge of making sure our patients have the right vaccines, because number one, we know what vaccines they need. Number two, we know what to tell them about their medicines. For example, methotrexate, we want them to stop it for a week or two after all vaccines so that vaccine works properly. And so that's, if you're on methotrexate, that's a very important point for you to remember. The reason for this, by the way, is that infections overall are the second most common cause of death. The second most common cause of death. Unfortunately, I know that there's people out there who don't believe in vaccines and try to tell other people they should never be vaccinated, and it's very frustrating to me as a doctor because I've seen many patients die of infections. I've rarely seen bad side effects from vaccinations. But the thing is that the vaccines, like for pneumococcus, which is for pneumonia, the flu shot every fall, 2 COVID shots every year for systemic lupus patients, a vaccination against human papilloma virus because which is using a vaccine called Gardasil because our patients get HPV infection and cancers from those HPV infections more than the general population. Most recently, RSV vaccines. And so it's important to make sure you keep up with your vaccinations because it will help prevent that second most common cause of death. Now I'd just like to show you a picture. This comes from the EULAR management recommendations for systemic lupus. They just did an amazing job. They actually packed all the stuff I just talked about into this little tiny diagram here. And just for example, I'll use my cursor. It's hard to see my cursor, but you might see my arrow floating around over there. But on the left side, you'll notice that it says that we should be doing sun protection, teaching our patients to exercise religiously, never smoking, eating a balanced diet, the Mediterranean diet, an anti-inflammatory diet. Just another thing I like to point out is, let's say our patients have moderate disease. For first-line therapy, so look in the middle where my arrow's circling around first line under moderate, all patients should be on hydroxychloroquine in green. We might use glucocorticoids or steroids, but we want to get them down to 5 milligrams a day or less. But in addition, we want to consider strongly combination therapy, adding belimumab or anifrolumab, which is Benlysta or Safnilo, or methotrexate, or azathioprine, or mycophenolate. And we want to teach our doctors to get this disease into remission like we see on the top right. So I just wanted to show you that's a really cool chart that they packed all of that into there. The next one is lupus nephritis. 40% of our patients will have lupus attack the kidneys, which is called lupus nephritis. N-E-P-H-R is the Greek word for the kidney. And the problem is that when it's not treated properly, lupus nephritis is the #1 cause of death and doing badly if someone dies from their lupus. But with today's therapy, the vast majority of our patients should never go into kidney failure. And I just picked out several important things from these recommendations, from these guidelines, by the way. Is #1, that doctors should be starting off with what we call triple therapy. And what we mean by that is using Benlysta or Lupkynis, which are the 2 lupus nephritis FDA-approved drugs, or another medicine called tacrolimus immediately in our patients, plus, and I've used abbreviations on here, sorry about that, but it's just the way that I could fit them on the slide. But using cyclophosphamide, which is also called Cytoxan, or mycophenolate mofetil, plus steroids, plus hydroxychloroquine immediately. The reason this is so important, by the way, is probably most lupus nephritis patients today are being treated incorrectly. They're being started on either mycophenolate or Cytoxan, plus steroids, and hopefully hydroxychloroquine, but many are not. And then the doctors see how they do. And then if they don't do well, then they add Benlysta, or they add Lupkynis, or they add tacrolimus. The problem with this is that in the past 20 years, we've had multiple clinical trials trying to find better medicines to treat lupus nephritis, and only 2 of them passed their primary endpoint. That was Benlysta and Lupkynis. But what was common in all of those is that the most common way to treat lupus nephritis, which was mycophenolate or Cytoxan and then steroids, only 30% of the patients went into remission. 70% did not go into remission, and a very high percentage of those patients end up in kidney failure getting dialysis, and getting a kidney transplantation. So if all doctors follow our advice and do triple therapy right away, their patients are going to do much better. The second thing is to use lower doses. Just a few years ago, I would treat my patients with 1,000 milligrams of IV solumedrol, called pulse IV steroids, and then 60 milligrams a day of prednisone. And then they would be on that for many months as we taper down the steroids. But now we know we can get away with much lower doses of prednisone. And just for example, I just had a patient who came to me with severe lupus nephritis. She was dumping 10 grams of protein in her urine every day. The normal is about 200 milligrams or less. So this was just crazy high, but I treated her with 500 milligrams instead of 1,000 milligrams of IV pulse steroids, followed by just 20 milligrams a day of prednisone. And I guarantee she's going to have much less side effects to prednisone. In fact, when I saw her just this past week, she was doing markedly better with her lupus nephritis using much less steroids. And then the third thing is how to tell if patients are responding to therapy. Many to most rheumatologists probably didn't even know how to tell how their patients were doing. The European Union League Against Rheumatism even published their lupus nephritis guidelines on this nice image in their paper, and the link will be given by Kelly at the end. But if you look on the very right, it says the targets. And at the 3rd month mark, for example, we want to have our patients have their urine protein decreased by at least 25%. At 6 months, by at least 50%. And then at 1 year, less than 0.7 grams per day. This is a lot of very technical talk, I know, for patients, but what I just want to get across is that now we're teaching all doctors how to aim for the right things that the lupus experts would do, and they can do that even if they're in the middle of nowhere with no lupus experts anywhere. The next thing, and this was the most amazing thing, the last day of the talks at the 2025 Toronto Lupus Get-Together last week, Dr. Arnaud got up in front of us and he announced that this particular paper was recently published just this week on how to treat 24 rare systemic lupus manifestations. The importance of this is that someone who develops severe lupus in the middle of nowhere with no lupus expert can go to this paper and know exactly how to treat it. And I like to show you the manifestations that he showed. This is a bad picture. I took a photograph of it and put it up. But if you look on the left, I'll just name off some of these. For example, aplastic anemia, interstitial lung disease, which is inflammation of the lungs. Going down a little bit, or meningitis, inflammation around the brain. Towards the bottom, there's seizures. There's vasculitis. There's polyneuropathy, where it attacks the nerves of the hands and feet. And so then, if you look to the right, it shows how often all these, what they did is they got together around 160 some lupus experts or more. The lupus experts named the rare manifestations of lupus, and then they wrote down how they treated their successful treatments in those lupus patients. And then they gathered all this information together. And then all of the lupus experts, they voted on which are the best treatments. And that's what they ended up publishing this. But just to give an example, let's look at lupus pneumonitis, which is number 8. Lupus pneumonitis, that's inflammation of the lungs. Out of all of these experts, and 95 experts voted for this one, when you look at those who have seen only 1 to 5 cases in their lifetime, that was 10% of them. And then look to the right of that, let's see, no, pneumonitis right here, number 8. So 48 doctors had seen 1 to 5 cases in their lifetime. 21 had seen 6 to 10 cases in their lifetime. And then they were able to vote on the best therapies for these. So this is just phenomenal that any doctor can now take much better care of lupus. And then brand new treatment, and this is the last thing I'm going to mention about, and then we'll be open for questions and answers. But there's brand new treatments just around the corner. During this past year, several medications passed their phase 3 clinical trials. That's the most important clinical trial research to have the FDA approve a medicine to be used in lupus. And just for example, there's a medicine called brentuximab, also called Gazyva, which I have some patients on it who are doing much better than the older therapies, but it will probably be FDA approved for lupus nephritis sometime in the near future. It's called Gazyva. Another one called deucravacitinib. It's been tested in systemic lupus, but also in skin lupus or cutaneous lupus. Did you know that cutaneous lupus or skin lupus is more common than systemic lupus? But there are no FDA-approved drugs for cutaneous lupus. I think that's going to change soon with this medicine called deucravacitinib, and then anifrolumab or Saphnelo. I suspect probably in a few years it will be FDA approved for cutaneous lupus as well. The future is very bright for systemic lupus, especially those who are just now presenting for the very first time. Bottom line is that the treatment for systemic lupus erythematosus has jumped forward an incredible amount, and I would have to say that Toronto 2025, the International Congress, that was the big celebration, was all these wonderful guidelines to show all doctors around the world how to take better care of lupus patients. And Kelly, I just wanted to share that with everyone. I hope I wasn't too technical for too many people, but I just wanted to make the point that doctors can know how to treat lupus. So that's it, and I'm open to any questions and that anyone might have for me.
Well, I'm glad that you're open to questions because there are sure a lot of questions here. Wow, so much information. I know my head is spinning because I am really intrigued by that 24 list of manifestations in lupus. That's really fascinating to me. So the first question comes from Lori, and let's just caveat this by saying not all questions can be answered by Dr. T because he's not acting as a reminder as your personal physician, but he can provide you with resources that you can in turn take back to your doctor and have an open and honest conversation about what is the best course of action for you. Just wanted to remind you of that. So this question is, what is the best advice for dealing with shrinking lung syndrome? Not just meds, but anything that might help with the reduced lung capacity.
Sure. So shrinking lung syndrome is a problem where the capacity of the person to take in a full breath and fill up their lungs with air is less than it should be. So the capacity for breathing in is shorter than it should be, and that's why we call it shrinking lung syndrome. We call it syndrome, by the way, Kelly, because we really don't know the cause of it. We don't know if it's because of inflammation around the lining of the lungs that's causing constriction, or is it because of a problem with the diaphragm, the muscle below the lungs, not able to take a full breath, and so the diaphragm goes up into the chest cavity, and that's what we see on chest X-ray. We see the diaphragm much higher than it can, and on pulmonary function tests, we can see that the patient is not able to breathe in enough air. So there's two ways to go about this. Number one, we're hoping that when we catch someone with shrinking lung syndrome where they're short of breath because of it, we're hoping that it's because of active lupus inflammation. So with that patient, we would treat them with high doses of steroids plus an immunosuppressant and plus hydroxychloroquine at the same time, hoping that their capacity improves over time. And by the way, most patients do get better over time. But unfortunately, some patients are caught by the time there's permanent damage. And the reason for that, we believe, is that there was just a very slow decrease in their capacity to take a full breath. There's probably permanent scarring that won't respond to anti-inflammatory therapies. But with these new 24 guidelines on treatment, doctors will know better how to treat it, and we're hoping we catch it at that early stage. And by the way, Kelly, I like that you like the paper about how to treat the 24 rare manifestations. The importance of that, by the way, is that let's say that we got someone with a severe lupus manifestation, like lupus pneumonitis or inflammation of the lungs. The way the doctor would learn how to treat that patient sitting in front of them is that they would go into the medical literature on Google, look up some case studies that have been done, and then see some that responded to therapy, then pick that one and treat the patient that way. But that might not be the best way to treat the patient. Now we know the best way to treat the patient. So that's why there's a celebration with how to treat these 24 rare manifestations.
Hmm. Wow, yes, that is just really hopeful for patients in the future and present patients as well. A follow-up question, Dr. T, how common is shrinking lung syndrome in SLE patients?
It is rare. That's why they put it in the list of rare manifestations. I don't know exactly the right number, but we know that it's less than 1%.
Okay, let's see. We have lots of comments about the different eye field testing. We have Stephanie who has a comment. She says she believes hydroxychloroquine has also helped reduce her psoriatic arthritis.
Yes, absolutely, Stephanie. We use hydroxychloroquine for a lot of different systemic inflammatory autoimmune diseases, and psoriasis and psoriatic arthritis is one of them. Even though most patients with those disorders don't respond to hydroxychloroquine, there are some that do. We also use it for rheumatoid arthritis, for example. We also use it to help some of our patients with scleroderma or systemic sclerosis. We also use it in Sjogren's disease, which is also another systemic autoimmune disease. So I'm glad it's helping you out, Stephanie.
There is a follow-up question that relates to this that kind of dovetails further down, so I might just ask it now. Someone was asking about mixed connective tissue disease and the use of hydroxychloroquine and whether that was encouraged.
Yes, absolutely. So first off, I'd like to describe mixed connective tissue disease and make an important distinction. There's two diseases that are oftentimes mixed up. One is one called undifferentiated connective tissue disease, and one is mixed connective tissue disease. And the problem is that even many doctors mix these up. And so I like to define them first. Undifferentiated connective tissue disease means that someone has a systemic autoimmune disease like systemic lupus, but it doesn't fit neatly into one of the categories. It doesn't fulfill the classification criteria, for example, but we know that over time they can possibly evolve into something like systemic lupus, and we still treat it the same as systemic lupus. We use medicines like hydroxychloroquine for people with undifferentiated connective tissue disease. Mixed connective tissue disease is completely different. Mixed connective tissue disease is like it sounds. It's a mixture of a couple or several systemic autoimmune diseases. All patients with mixed connective tissue disease have a very high anti-RNP antibody. You can't have MCTD or mixed connective tissue disease without that. Now, unfortunately, too many patients are told that they have mixed connective tissue disease because they're anti-RNP positive. That's completely wrong, because 30% of our lupus patients, for example, are positive for anti-RNP but don't have mixed connective tissue disease. So mixed connective tissue disease patients, the vast majority have Raynaud's phenomenon, where their fingers turn white or blue with cold exposure. Most of them have inflammatory arthritis that can look similar to lupus arthritis or rheumatoid arthritis. Most of them have puffy fingers, where their fingers are swollen or puffy, almost like what we see in scleroderma. And many of those patients will respond to hydroxychloroquine, and probably it's best for most to all of those patients be on hydroxychloroquine. But we also use medicines like steroids, methotrexate, and mycophenolate mofetil. And by the way, I know that someone must have mixed connective tissue disease if they ask that question. Our biggest fear over time, and this is important for you to know, is something called pulmonary hypertension, because pulmonary hypertension for some reason occurs more often in MCTD. Pulmonary hypertension is where the blood pressure becomes too high in the arteries of the lungs, and that can be very dangerous as far as breathing ability. Most of our patients don't get it, but it's common enough that we want to screen our patients regularly. We want to get pulmonary function tests and an echocardiogram every 1 to 2 years to make sure it doesn't happen. So if you're not getting that done, make sure to bring it up to your doctor.
Wow, that was a lot of very helpful information. Um, Once again, I'm just thinking of how many patients are just scribbling all these notes down as you're talking. And also, it just hit me. I just had this kind of flood over me of thinking about how many patients are misdiagnosed and potentially not treated appropriately because of that misdiagnosis in the beginning, and how so many of these autoimmune conditions, connective tissue disorders, just overlap. I appreciate you spending time to break them down and talk about the differences between mixed connective scleroderma and undifferentiated, because I would assume that the majority of us haven't had a doctor explain in such nuanced ways the differences. And maybe someone watching today might say, I think I might be more in the mixed connective, and talk to their doctor about doing the tests, the antibody tests, and really delving into a diagnosis that is accurate and will lead to a better treatment and hopefully better outcomes.
Yeah, so the question is how often are patients misdiagnosed and undiagnosed? Kelly, I specialize in lupus and Sjogren's disease, and guess what? I have misdiagnosed way too many patients. Today, I misdiagnose too many patients. Every single rheumatologist, no matter how good they are, misdiagnose too many patients, and there's reasons for that. Number one, our laboratory tests are not nearly as good as they should be. Did you know that the vast majority of the tests that we do to diagnose systemic lupus, Sjogren's disease, and so forth, are over 55 years old? Over 55 years old, they are inadequate. Now, there have been much better laboratory tests that have been found and discovered in the past 25 years. But the problem is that it's incredibly hard to convince the FDA and Medicare and Medicaid that we need to get these labs into clinical practice. The reason for that is that these are discovered by small laboratory companies, and these small laboratory companies don't have very much money. It's very different than a huge pharmaceutical company. For example, let's say Johnson & Johnson, for example. They have billions of dollars, and they can fund research for medications and get it through 3 clinical trials. The small laboratory companies, they just don't have the money to do that, and it's incredibly frustrating. We have a test, for example, by a company called Exogen out in California. They discovered this amazing test called CB-CAPS, which is it's called the Avise Lupus test, the Avise Connective Tissue Disease test. It's more sensitive and more specific than the current tests like anti-double-stranded DNA and anti-Smith antibody that all of you have probably been tested for. But guess what? And these were discovered 25 years ago, and they've been available since 2016. But the vast majority of doctors have no access to these tests because insurance companies won't pay for them. They say they're experimental, even though that they've been proven in lots of research studies to be excellent. Right now, there's a wonderful test called urinary biomarkers, which they can actually tell us if someone has lupus nephritis. And when we put the lupus nephritis patient on treatment, they actually tell us if the patient's getting better. And these tests are currently out there and will soon be available, but I bet it's going to be very hard to get into my hands, and I'll have to just do a lot of kidney biopsies instead of using these urine tests instead. So unfortunately, lots of mistakes have happened. The other thing is that systemic autoimmune diseases they like to change over time. Just for example, someone might come in with a high rheumatoid factor, an anti-CCP antibody, a lot of inflammatory arthritis. That patient has rheumatoid arthritis. Put them on methotrexate right away. And then a few months later, they get some Raynaud's phenomenon. A few months later, they get this malar rash. No, that patient has systemic lupus. All along, the systemic lupus was the cause of the rheumatoid arthritis, not rheumatoid arthritis. So that's the other problem, is how these systemic autoimmune diseases are just so tricky and elusive and change over time as well. So, so those are a couple of the reasons, Kelly. We are getting much better with diagnosis, because I do use those new tests in my office, but unfortunately most doctors don't have access. It's very frustrating.
Wow, that is so fascinating. I can't wait to hear more about the urine test and being able to test kidney function levels from that. Imagine having to not do a kidney biopsy right off the bat. That would be, I think, a tremendous way to sidestep a lot of patient anxiety, because I know patients get very apprehensive when they're told they need a kidney biopsy, and that could be something that can be put off or maybe sidestep, which is not good. So that is really, really good to hear that's coming along. Also,
Yeah,
a follow-up.
And just to put that in perspective, Kelly, I will say that probably we'll never get rid of that first kidney biopsy, because it's really the only way to actually visualize exactly what's going on, and the urine test will help us also confirm that as well. But what it's going to be especially helpful for is, right now we have to get repeat kidney biopsies in most of our patients, and that's the scary, especially scary, and cause a lot of anxiety. We might be able to get rid of those additional kidney biopsies. And Dr. Andrea Fava at Johns Hopkins, he's been one of the leaders in this, and I bet you within a few years we'll have those tests available.
Wow, wow. Thank you so much for clarifying. That is very helpful. A follow-up question as well. We had a few people comment about your anti-nuclear antibody test. And there's been a lot of weight, obviously, put on that test over the years as being the test to determine, along with the classification from the American College of Rheumatology, that justifies a lupus diagnosis. But there are questions regarding how high the ANA should be in order to kind of question, maybe it's mixed connective versus scleroderma versus SLE. Do you have any insights on that, the titer levels? Because people really are interested in knowing kind of what a high is, and you know, how many people just naturally have a high, or have a positive, I should say, ANA. I know we're kind of running out of time here, but
yeah, so the bottom line is, the higher the ANA titer or result, the most likely that there is to be a systemic autoimmune disease in that particular patient. And the way this test is done, by the way, is I'll describe it. The lab technician, they take these special cells called HEP2 cells, and then they take the patient's serum, they put it on top, and then if the patient's serum has antibodies that are directed towards any of the proteins or antigens in the nucleus, it binds to those antigens in that nucleus, and then they light up. They actually fluoresce because they tagged it, those antibodies, with a little fluorescent tag. The technician looks through a microscope, sees them reflecting, and then it's a positive test if they can see it the nucleus light up. And then what they do is they add an equal amount of fluid to that serum, and that would be called a 1-to-1 mix. And that's going to be positive in the vast majority of normal people, by the way. And then they add the same amount of fluid again to that mix, and that's called a 1-to-2 mix. And then it's going to be a 1-to-4 mix, and then a 1-to-8 mix. And as it's dilated more and more and more, that result is going to be less likely to show up on the test. And so the higher and we call that the titer. So a 1-to-4 or a 1-to-8 or a 1-to-40, a 1-to-80, those are higher levels. And in most laboratories, the cutoff is about 1 to 40 or 1 to 80. So when we look at patients with an ANA of 1 to 40 or 1 to 80, the vast majority do not have a systemic autoimmune disease. If you go out and grab a bunch of people off the street that are healthy, a high percentage of them, up to 20%, will be positive for those low titers. But if you look at a high titer like 1 to 3,200, which we actually absolutely do have, or 1 to 1,600, they have a significantly higher chance of having a systemic autoimmune disease. So it's like a continuum with the strong amount of tests, or the ANA, but it doesn't help differentiate lupus from scleroderma from rheumatoid arthritis. For that distinction, we have to look at the type of ANA. For example, is that ANA due to anti-Smith? Oh, if it is, then that patient most likely has lupus. Is that ANA, is it an anti-centromere antibody? Oh, yes, it is. Then that patient may have scleroderma. And so that's how we can help differentiate.
There we go. You heard it here, everyone. Okay, so I think we have just a few minutes left, and here's a question regarding overlap syndromes. Jill, she says, does having overlap syndrome, 2 or more autoimmune diseases, make SLE more difficult to get into remission or low disease activity? I have MCTD with SLE and scleroderma. Thank you.
Okay, yeah, that's a great question. I really don't even know if that's been studied, to be honest. It may have, but if it has, I have not seen the research myself. So first off, the difference between an overlap syndrome and mixed connective tissue disease is very different. Mixed connective tissue disease is a systemic autoimmune disease of its own. An overlap syndrome is when someone has 2 or 3 or more systemic autoimmune diseases at the same time. For example, this patient, I suspect that they fulfill classification criteria for systemic lupus as well as scleroderma, or also called systemic sclerosis. Now, when I see a patient with that combination, by the way, it is going to be harder to treat it. But it's going to be harder to treat it because of the scleroderma part. We have such a great difficulty treating scleroderma. We don't have any FDA-approved drugs for the systemic disease, only for the lung disease by itself. And so for scleroderma, there's a huge unmet need for better treatment. So I'm much better at getting that systemic lupus part under control, but it's much more difficult to get the scleroderma part under control.
Oh, thank you for answering that. Let's see here. If I can just get one more last one in. What is your advice for someone who has intolerance to most medication and has extreme and consistent CNS symptoms and has already been on steroids for a year that caused osteoporosis?
Yeah, boy, I really hate to hear this. And this is one of those things that, even though I said that most of my patients are in remission or low disease activity and not on steroids, I have patients just like you. And it's very frustrating for me as the physician, and certainly, definitely you yourself, because we're just still limited in the number of medicines that we have to treat patients who fail so many different medicines, because there are patients who just don't tolerate so many different medications. And so I would reach for those that are not commonly used, and I'll just name some of them. So obinutuzumab can be used if you've never been on it before. It's also called Gazyva, G-A-Z-Y-V-A. I have a patient, for example, who's on it. Fortunately, the National Institutes of Health, or the NIH, has been very instrumental in getting that patient on the medicine for me. But now it's probably going to be much easier since the phase 3 clinical trial for lupus nephritis did so well. So that's a medicine I would grab for. Another one that's not commonly used is tacrolimus. Nice thing about tacrolimus is we can measure drug levels. I recommend getting a drug level of 4 to 8 nanograms per milliliter. So I start off with just 1 milligram twice a day and slowly go up on the dose as tolerated and reach for those levels. Another one that's not commonly used is sirolimus. Sirolimus. That's another medicine that's rarely used, but it absolutely can be very helpful in lupus patients. By the way, hydroxychloroquine, if you couldn't tolerate it for some reason, and if it was mainly an allergic reaction or severe stomach upset or headaches or things like that, there is a way to still try to take it if you're not able to take it. It's just, we can actually prescribe 100 milligram tablets instead of 200, and I ask my patients to cut them in fourths. So just take 25 milligrams a day, just a teeny weeny tiny amount, and then a week later go up to 2 tablets a day, a week later up to 3, and so just starting with the lowest doses possible. Same thing with methotrexate. If you couldn't tolerate methotrexate, a lot of times it's just stopped and not even tried again. But another way to do it is to start off with an incredibly tiny dose, like maybe a half of a tablet, but then also using a vitamin called leucovorin instead of folic acid. Leucovorin is much better or much more likely to help the patient tolerate it. So there are other tricks that can be tried that not all rheumatologists know about. And by the way, I do list these on my website, lupusencyclopedia.com. And so if you go in there, for example, and search tips for taking hydroxychloroquine, you'll find the blog article for that. If you do for methotrexate, you'll see my tricks for getting people to tolerate that as well. So there are little tricks as well.
Fantastic. Once again, all of Dr. Thomas's resources and sources shared today will be available through links in the comment section after we end the chat. And highly encourage you all to check out www.lupusencyclopedia.com. And Dr. Thomas, once again, thank you so much for your time and the incredible pearls of wisdom shared in today's event. This will be available as well on YouTube and downloadable for those that do not have Facebook. And we are just so thrilled to be able to close out Lupus Awareness Month with such helpful and resourceful information today. And Dr. Thomas, where can people find you these days? What are you up to these days?
Still in practice in Greenbelt, Maryland. I'm not accepting new patients myself at this time, but I might in the near future, Kelly. The reason for that is that we were forced to start doing electronic health records about a decade ago, and it's just horrible. I feel like a secretary all day long, and I can only see about 10 patients a day, and it's just so frustrating. But now we have artificial intelligence. We have something called Scribe AI, and it's just amazing. The computer sits there, listens to me with the patient, and then writes the note, and it's amazing how accurate the note is. So I'm practicing with this, and if it works as good as it sounds, I might start seeing new patients again. So that's one thing I'll say. I'm a possible bright future.
Wow, technology.
Yes.
Working for our advantage.
Yes. Especially with the rheumatology shortage, it's really important that we be able to see more patients.
Absolutely. And I will say I'm sitting here in Hawaii right now, and without technology, I wouldn't be able to do this. So appreciate that in this venue as well. Well, thank you again, Dr. T, for everything you've done today and sharing your insights on how to live your best life with lupus. Once again, thank you to all who joined as well, and look for those sources to come after we log off here. And even though Lupus Awareness Month is coming to an end, we never stop pushing forward with increasing awareness about this disease and reaching out to those and bringing them into the fold of community to resources and support here at More Than Lupus. So thank you again, and we will see you soon. Bye-bye for now, Dr. Thomas.
Goodbye, everybody.